Thank you, and it's truly an honor to give this lecture for this great event, and in such great company, and for this really exciting project that is mechanical thrombectomy that Dilip and Fawaz and many others have led and taken to an incredible level. So I'm going to outline sort of my thoughts about where we stand after 10 years. It's been an incredible journey, as Dilip pointed out. These are my disclosures. It all started, we became legal, so to speak. We were all working illegally for many years, but we became legal once these trials were published in 2015, and that has opened up everything in mechanical thrombectomy. And I'm gonna just very briefly outline the technology. I think that that's the area where we've made the biggest progress. There is a bunch of stent retrievers which really have been the driver for sure of these of this revolution in thrombectomy. At the end, it was all about technological advances, in my opinion. Then came aspiration devices. Now we're talking about 088 catheters in the brain. We've made incredible technological advances, and that's probably the biggest progress we've made. And as I will outline before, there is a lot of need for more advancements, which should probably not be focused on technological advances, because I think that the progress from now on the technology side is going to be incremental. We're going to get a lot more bang for the buck in terms of improving outcomes if we focus on other aspects of this procedure. And so I'm not going to spend too much time on the technical aspects of the procedure. Suffice to say, where I think there is still some need for refinement, especially worldwide, where ICAD is more prevalent as a cause for acute intracranial occlusions, is with our ability to manage acute intracranial occlusion due to ICAD or other refractory lesions. There's some controversial data. We have Angel Reboot, which of course was a randomized trial, but involved a lot of angioplasty. Then we have registry data more focused on, and Reboot was a negative trial. Then we have registry data that suggests that when we actually do stenting, there may be some benefits. Again, registry versus randomized trial, very different. We need more clarity in that regard. But that, to me, from a procedural side, that's a big need for further clarification. Also, in the realm of stenting, we have tandem occlusions, which I think by now it is becoming clear, although we do not have level 1 evidence. That's work in progress, the Picasso trial, that probably stenting is better than no stenting in tandem occlusion. It's also something that we've sort of improved. And if you look at the 2015 trials and the Hermes meta-analysis that followed it, individual level meta-analysis, there were a lot of questions and a lot of patients that were not necessarily included, including the large core patients. Although the signals, we kind of ignored them, even the large core patients, which by design were largely excluded from these trials, even though there were signals of benefit, but again, largely excluded. M2s, largely excluded, and NIH stroke scale score of 10 or less. Again, uncertainty as far as benefit. We already saw the signals of extended time window and evidence of benefit there. And then tandem lesions, again, we saw evidence of benefit. The overall disability, and I'm not going to spend too much time on this, the overall treatment effect as far as disability shift was 2.6, which is vaccine or antibiotic kind of treatment effect strength, unprecedented almost in the procedural realm. And yet, as Dilip very clearly pointed out, we're far behind in terms of implementation of this life-saving or disability-saving treatment. Of course, the central dogma is that this is a exquisitely time-sensitive treatment. It doesn't mean that we're limited by time, but the earlier we treat the patient, the higher the chance of a good outcome. The reason why we're not limited by time is because we have a great variability in collaterals. We have fast progressors and slow progressors. And as far as slow progressors, these are excellent targets for revascularization in the extended time window. And that's been actually shown. This has been a sort of the second big breakthrough with extended time thrombectomy in the extended time up to 24 hours in DAWN and Diffuse 3 trials, which have basically shown the strongest treatment effects reported in thrombectomy trials. That's because these patients were highly selected. In the Aurora meta-analysis, the sort of the equivalent of Hermes, again, very strong treatment effects, number needed to treat of 4, when all patients treated beyond 6 hours were included. And one very interesting thing about the Aurora meta-analysis was that when in subgroup analysis, the only treatment effect heterogeneity was noted with regards to time to treatment, in the sense that patients were treated later, were randomized later, so to speak, or treated later, 12 to 24-hour time window. There was stronger benefit than in the early time window observed. That doesn't mean that there is a better prognosis. These patients didn't necessarily do better, but the delta, and that's a very important concept that we're still sort of digesting, that there is a big difference between prognosis and treatment effect. And that's coming across over and over again when we talk about age, when we talk about large core, etc. And it applies also to the time window. It appears that in Aurora, and when we select patients very strictly based on core size, that patients who are treated later benefit more than the ones who are treated earlier. I'm not going to go into the current state of mechanical thrombectomy, as Dilip very articulately pointed out in his previous presentation. We're lagging way behind of what we should be doing. Empty glass again pointed that out. Even in the highest users of mechanical thrombectomy by country, which is Australia, with still 50%, less than 50% of what should be treated is being treated, and that's where I think is the biggest chance for improvement, the biggest opportunity. So, what's the current state of mechanical thrombectomy? These are some of the recent registries that have been published. What you can see is that, again, as I mentioned, we've made fantastic progress in terms of our ability to reperfuse the brain. There are now technologies where 50% of the times we get TICI 2C, first pass revascularization. We open up, if we look at TICI 2Bs, which I think is kind of an obsolete modified TICI 2B way of assessing success of reperfusion. But when we use this standard, almost 100% of the times we're able to open the vessel. So we've figured that out. That's one thing that we clearly figured out. There's still, you can quibble about some need for further refinement. There always is. but the gains that we're making now are incremental. And that's sort of illustrated in the fact that if you look at the rates of functional independence, they are slightly better, but not that much better than what we've seen in Hermes. So when we talk about, yes, we've made all these technological advances, but have we actually improved outcomes? And that is only in a few percentage more of patients that we treat. And that's because we are doing a poor job at workflow, whether it's extra hospital or intra hospital. Here, if you look at our door to groin puncture times, it hasn't really improved much compared to the Hermes times. And so those are real areas of opportunities, because if we bring down these numbers, that's where we're going to see huge increases in and progress in terms of outcomes. The thrombectomy device, a better technology, it's unlikely to move these clinical outcome rates. What's gonna give us the biggest bang for the buck is systems of care and access to care, and that's, I think, where the big challenge is, and where organizations like MT 2020 and projects can make a huge difference. And I'm very proud and happy to be part of that. So another landmark development has been the large core trials. All these trials that I showed you in Hermes and extended time window trials did not include patients with the large core. We thought that we're actually harming these patients. That's why we didn't include them. But as I showed in the Hermes subgroup analysis slide, some of these patients squeaked through because of pretty much inadvertently, based on investigator as opposed to core lab assessment of infarct size. And lo and behold, it seems like there were signals of benefit in these trials, in these analyses. And so that generated these large core trials, which for me represent another major breakthrough, because this is a very important segment of the thrombectomy population. They're only making about 10% of patients, but very importantly, because I think it has the potential to change systems of care. These trials have been done. There's 6 of them. They've been done in all continents and involving all sorts of selection criteria, MRI, advanced imaging, you name it. But I'd like to highlight, not because I had the privilege to be one of the principal investigators, but because one of these trials had no limit on the upper size of the infarct. All of these trials had a lower size infarct limit, which was an aspect of 5. LASTE had no limit on the size of the infarcts. In terms of results overall for these trials, including LASTE, which again had a median infarct volume of 130 cc's, no limit, included all patients regardless of core size. And all these trials have shown exactly the same results, meaning there is benefit, except for Tesla was statistically significant. Tesla was very close, but even Tesla was positive at 1 year. With strong signals, 2 of these trials showed also, as opposed to the other anterior circulation randomized trials, mortality benefit. And yes, there is some higher rate of symptomatic hemorrhages, non-statistically significant in these trials individually, but I'm sure combined there will be. But that's kind of akin to intravenous TPA. We get better outcomes at the expense of slightly higher rate of symptomatic hemorrhage. Also with large core thrombectomies, many have said that yes, we're saving lives or whatever, but we're transforming, we're generating a lot of undesirable outcomes, rankings 5 or 4. That actually turns out not to be the case. This is LASTE. Mortality was 20% less in LASTE, and pretty much all these patients that the lower mortality, these 20%, was shifted in towards ranking 3. The rankings 4 and ranking 5s were the same percentually. The big gain in percentages was basically pretty much all found in the ranking 3s, which most of us will agree is a desirable state and preferable to death. So this has been a sort of a major breakthrough as well, and the large core trials, and that has sort of generated the guideline document from the Society of Vascular and Interventional Neurology, which I think is a document for the ages. It basically states that there is level 1 evidence for thrombectomy in the 0 to 6 hour time window, regardless of imaging. And that's a very, very important point. As I said, I think this kind of knowledge, this kind of advancement in knowledge will change systems of care. With regards to 6 to 24 hours extended time window, there is a recognition that the data is not sufficient to make recommendations for patients with the largest of the largest infarcts, aspects 0 2. Pretty much the other aspects 3 to 5, proximal large vessel occlusion, anterior circulation, also level 1A. And what that means is that pretty much it's being recognized that this opens up the way to less imaging, as little imaging as possible, especially in the early time window, just consistent with the findings of one small randomized trial that needs to be replicated, of going directly to the angio suite, which has shown benefit when we go directly to angio, forgo any kind of imaging, treat the patient as quickly as possible in the early time window, 0 to 6 hours, with patients with high likelihood of large vessel occlusion, NIH stroke score 10 or above, given TPA based on flat panel technology, if available, and that has been shown to be safe and leads to statistically significant improvements in patient outcomes. So, and then if we look at imaging requirements beyond 6 hours, I think, again, that's where we're dealing more with fast progressors. We don't get punished that much, but it appears that, and that's something that has implications worldwide and implications with regards to access to thrombectomy worldwide. It appears, and that's a bit of work in progress, but it appears that we do not need advanced imaging, even in the 6 to 24 hour time window, to select patients for mechanical thrombectomy. Now, moving on to low NIH stroke scale score, this is also something that has not been established. If you remember the Hermes meta-analysis, patients with low NIH stroke scale score, there was no statistically significant benefit, especially NIH stroke score less than 10. Most of the initial trials, or most of the randomized trials, have not included these patients. They make up about 15% of patients with large vessel occlusion stroke. And we know that a certain percentage of patients, which is really the crux of the matter, do experience early clinical worsening. If they don't worsen, they do well. But so the balance, the question here, the bet is, should we treat these patients to be pretty much address the ones with early clinical worsening, taking into account that there is some procedural risk. This is a work in progress and is being addressed by two major studies. The MOSTE study in Europe and the United States has already about 700 patients enrolled. ENDOLO, which has been enfolded in the STEP platform, is the second trial, and we're looking forward to finding out whether we should be treating these patients. It is unclear at this point whether we should. So how about intravenous TPA? And And mechanical thrombectomy, that's an area of great interest and passion. We have now, luckily, abundant level 1 evidence. It's the iris, the core crystallized in the iris meta-analysis. This is data from 6 randomized trials, over 2,000 patients. Should we administer TPA or not prior to thrombectomy in patients presenting directly to thrombectomy centers? We're not ready yet to forego this in patients not presenting directly. The findings are that IV thrombolysis is better, but the treatment effect is small, with a number needed to treat of 57. So we should make individualized decisions. I think most of these patients should get TPA unless there is a compelling reason not to do so. One of these reasons, because IV before thrombectomy has not been looked at in patients with large core. It may be that in patients with large core, it may be better to forego intravenous TPA. We don't have level 1 evidence in that regard. But there are some signals that may be the case. Also, we should keep in mind that the benefit of intravenous thrombolysis before thrombectomy has been shown to be strong or be present, or statistically significant association only in the early time window. After 2 hours and 20 minutes, this association loses statistical significance. So that's an important thing to keep in mind. And the findings of trials that have looked at thrombectomy, thrombolysis before thrombectomy in the extended time window have been negative. The timeless study, so that is completely consistent with the IRIS meta-analysis showing benefit for intravenous thrombolysis only very early. There's a lot of opportunities, as I mentioned. The outcomes are not as, we haven't made a big difference in terms of outcomes. We are doing much better compared to no treatment, but over those last 10 years, our outcomes have not improved when we treat the patients as much as we hoped. We hoped that one of the measures that will, or interventions, will be combining neuroprotection with reperfusion. This concept has been reappraised because reversible models of MCA occlusion were not available when the multitude of neuroprotectant agents that were negative were tried in the past. This is still work in progress. Unfortunately, we have a few phase 2 trials that were positive, but no phase 3 trials yet. I still am hopeful that that we will reach that holy grail of outcome improvement with neuroprotection. A big hope in that regard is the fact that it's been now shown twice in randomized trials that neuroprotection can be used in the field, and that people can be treated within 60 minutes of stroke onset, which is an incredible concept. And perhaps that's sort of the future of neuroprotection, ultra early administration in the field. Another very interesting development is intraarterial lytics post mechanical thrombolysis, primarily to address the microcirculation. The first such trial showing benefit was the CHOICE randomized trial, which was then confirmed by several other randomized trials, including TPA and TNK. The interventional community has been a bit slow in adopting this strategy, but I think we have level 1 evidence in support of it at present. Posterior circulation has been sort of less well studied, if you want, in terms of numbers of patients. It's also a bit less common, about 20% of thrombectomy cases, 15 to 20%. We have now level 1 evidence of benefit from randomized trials, attention and Bao-Chu trials. This has been recently published in an individual level meta-analysis. The Veritas meta-analysis published in Lancet last year. Again, robust treatment effect across all subgroups of these 1,000 patients randomized, except, as usual, it's the same sort of factor that comes up: low NIH stroke scale score, mild strokes. That's something that we need to clarify in the future, whether there is or not benefit. And since we are at the topic of mild strokes, we should also mention the medium to distal vessel occlusion trials. If you look here, early window, extended window, large core, everything is positive. MEVO, which was largely defined by non-dominant M2s or more distal anterior circulation, or PCA in the posterior circulation, we see a reversal of these numbers. It looks like these patients did better when they were not treated with thrombectomy, which really has generated a very nice editorial asking whether this is the limit of thrombectomy. I think, as it is with everything else, the answer is not that clear, but because there were, I think, perhaps too optimistic assessments of likelihood of benefit in these trials. First of all, including patients with low NIH stroke scale score who have distal occlusions on top of it makes little sense to me. Certainly, retrospect is easier to say that, but I think that probably was one of the most important reasons why these trials were negative. And there was also concern about selection bias. Patients treated and enrolled in these trials were older and had lower NIH stroke scale score than your typical patient population. That perhaps there are some technology limitations or room for improvements. General anesthesia, if you have somebody with a distal occlusion, should you put them under anesthesia? These are all very important questions, and again, work in progress. Now, since we're talking about anesthesia, I think that's another largely neglected issue that we need to clarify. There's been multiple trials. If you put them all together, general anesthesia versus conscious sedation, it looks like conscious sedation has an edge. However, when you look, when you do only randomized trials, and there've been a few of them, small centers, a small number of patients, few centers that participated, the edge, the advantages in favor of general anesthesia. This author here says, end of the confusion, general anesthesia improved patient outcomes. I think I'm still very confused, and I think that's something that we need to definitively address. There are important aspects that have to do with peri-procedural management of thrombectomy patients. Simple stuff like how do we manage the blood pressure. Over the last 10 years, our view on this, I think, has radically changed. And now several studies that have done and meta-analysis thereof seem to indicate that, in fact, conservative therapy, letting the blood pressure ride just along similar criteria that have been applied in post-intravenous thrombolysis, is better in terms of outcomes than what we all have done. I think most of us, at least, intensively lowering the blood pressure after reperfusion. That again plays into the neglected role of the microcirculation and the effects of blood pressure on the microcirculation. So in conclusion, I would say, where are we now? I think there's been a few things that we have successfully accomplished. And the most important thing is that we've generated level 1 evidence, certainly in the early and extended time window, that have been revolutions in the way we approach acute stroke patients with large vessel occlusion, in the posterior circulation, large core patients, intravenous lytics, and mechanical thrombectomy. And then lytics post-mechanical thrombectomy. We have incredible technological procedural advances that are now enabling us to open up these vessels almost all the time, 90% of the times. And I think, as I mentioned, any kind of further progress is going to be incremental. And we have increased our workforce and refined systems of care, although not nearly sufficient, in my opinion. But there's a lot more, a lot more things to be done, and I think that's where MT 2020. I'm so proud of what has been accomplished by Dilip, Fawaz, Santi, the entire SVIN and other societies that have brought this to a reality, because this is the kind of stuff that will actually lead to better outcomes and more patients treated worldwide. So what we're actually totally or where we've done a poor job is that adoption of thrombectomy, access to thrombectomy. As Dilip showed, there's massive worldwide disparities. And then even in the most sophisticated systems of care, we still have ways to go in terms of refining our extra and intra-hospital systems. We're doing too much imaging. We're taking too much time to get these patients treated extra outside of the hospital and inside of the hospital. We need to refine the role of stenting, and we need to push for improvement in outcomes outside of just the technology that allows us to open up these vessels, whether it's adjunctive therapies, whether it's a peri or intra-procedural management, and very, very important, recovery, because I think in parallel to the revolution of mechanical thrombectomy, there is, or a bit delayed if you want, a revolution in recovery modalities, and all these things need to be improved in order to get not to 50% good outcomes or functional independence, but 90%, 80%, 90%. That's where we need to be. So with that, I'm going to end. Thank you again for inviting me to talk, and I'm not sure if there are questions. Thank you.